Question 1. The audit findings indicate a discrepancy in the documentation regarding the management of a patient with persistent asthma. The therapist's notes describe the patient's medication as a long-acting bronchodilator that reduces inflammation. Based on the provided prescription for Montelukast, which of the following best reflects the accurate classification and primary mechanism of action of this medication in managing the patient's asthma? Option A. Montelukast is an inhaled corticosteroid that suppresses inflammatory responses in the airways through various cellular mechanisms. Option B. Montelukast is a long-acting muscarinic antagonist that blocks acetylcholine's effect on airway smooth muscle, leading to bronchodilation. Option C. Montelukast is a leukotriene modifier that inhibits the action of cystinyl leukotrienes, thereby reducing airway inflammation and bronchoconstriction. Option D. Montelukast is a short-acting beta agonist that provides rapid bronchodilation by stimulating beta-2 adrenergic receptors. The correct answer is C. Montelukast is a leukotriene modifier that inhibits the action of cystinyl leukotrienes, thereby reducing airway inflammation and bronchoconstriction. Explanation. The audit findings indicate a potential gap in the respiratory therapist's understanding and application of leukotriene modifier therapy, specifically concerning Montelukast. This scenario is professionally challenging because it directly impacts patient care and safety, requiring the therapist to accurately assess the medication's role, potential adverse effects, and appropriate patient education. The challenge lies in ensuring that the therapist's knowledge aligns with current evidence-based practice and regulatory guidelines for respiratory care. The correct approach involves accurately identifying Montelukast as a leukotriene modifier that inhibits the action of cystinyl leukotrienes, thereby reducing airway inflammation, bronchoconstriction, and mucus production. This understanding is crucial for its appropriate use in conditions like asthma and allergic rhinitis. The therapist must also be aware of common and serious side effects, such as neuropsychiatric events, and be prepared to educate patients and their families accordingly. This aligns with the Certified Respiratory Therapist (CRT) scope of practice, which mandates competent and ethical patient care, including understanding pharmacotherapy. Regulatory frameworks for respiratory therapists emphasize patient safety, accurate medication management, and effective patient education, all of which are addressed by correctly identifying the mechanism, side effects, and examples of leukotriene modifiers. An incorrect approach would be to mischaracterize Montelukast as a bronchodilator or a corticosteroid. Misclassifying it as a bronchodilator would lead to incorrect expectations regarding its immediate effect on bronchospasm and potentially delay the administration of rescue medications. Misclassifying it as a corticosteroid would lead to confusion about its administration route, potency, and side effect profile, potentially resulting in inappropriate patient management and education. Another incorrect approach would be to focus solely on the therapeutic benefits without acknowledging or being prepared to manage potential adverse effects, particularly the neuropsychiatric events associated with Montelukast. This failure to consider the full spectrum of the drug's impact violates the ethical obligation to provide comprehensive care and the regulatory requirement to monitor for and report adverse drug reactions. Professionals should approach such situations by first recalling the fundamental pharmacology of the prescribed medication. This involves understanding its drug class, mechanism of action, therapeutic indications, and known side effects. When faced with an audit finding or a clinical question, a systematic review of the medication's profile, referencing reliable sources such as drug compendia, professional guidelines, and peer-reviewed literature, is essential. This ensures that patient care decisions are evidence-based and compliant with regulatory standards. Question 2. Compliance review shows a patient's arterial blood gas results indicate a PaO2 of 70 mmHg and an SaO2 of 90%. The respiratory therapist notes that the patient's body temperature is elevated. Considering the principles of the oxyhemoglobin dissociation curve, what is the most appropriate interpretation and action for the respiratory therapist? Option A. Recognize that the elevated temperature will shift the oxyhemoglobin dissociation curve to the right, indicating that hemoglobin will release oxygen to the tissues more readily at this PaO2, and communicate this finding and its implications to the physician. Option B. Inform the physician that the patient is hypoxemic because the PaO2 is below 80 mmHg, and suggest a significant increase in oxygen therapy without further assessment of the dissociation curve. Option C. Document the PaO2 and SaO2 values as within acceptable limits and take no further action, as the SaO2 is above 90%. Option D. Recommend an immediate increase in the patient's inspired oxygen concentration based solely on the PaO2 of 70 mmHg, without considering the SaO2 or other physiological factors. The correct answer is A. Recognize that the elevated temperature will shift the oxyhemoglobin dissociation curve to the right, indicating that hemoglobin will release oxygen to the tissues more readily at this PaO2, and communicate this finding and its implications to the physician. Explanation. This scenario is professionally challenging because it requires the respiratory therapist to interpret complex physiological data related to oxygen transport and apply it to patient care decisions, all while adhering to strict regulatory guidelines for documentation and communication. The therapist must demonstrate a thorough understanding of the oxyhemoglobin dissociation curve and its implications for oxygen delivery to tissues, ensuring that interventions are evidence-based and patient-centered. The correct approach involves accurately assessing the patient's oxygenation status by considering the relationship between partial pressure of oxygen, PaO2, and hemoglobin saturation, SaO2, as depicted by the oxyhemoglobin dissociation curve. This includes recognizing factors that shift the curve e.g., pH, temperature, PCO2, 3-DPG, and their clinical significance. The therapist must then communicate these findings and their implications clearly and concisely to the physician, adhering to established protocols for reporting critical values and recommending appropriate therapeutic adjustments. This aligns with the respiratory therapist's scope of practice as defined by regulatory bodies, emphasizing patient safety, accurate assessment, and collaborative care. An incorrect approach would be to solely focus on the PaO2 value without considering the SaO2 or the position of the oxyhemoglobin dissociation curve. This fails to provide a complete picture of oxygen delivery to the tissues and could lead to inappropriate treatment decisions. Another incorrect approach would be to document findings without communicating them to the physician, which violates the principle of timely and effective communication essential for patient management, and could be considered a breach of professional responsibility and regulatory requirements for reporting critical patient information. Lastly, making treatment recommendations without a clear understanding of the underlying physiological principles or without consulting the physician would exceed the therapist's scope of practice and pose a significant risk to patient safety, violating ethical and regulatory standards. Professional reasoning in such situations involves a systematic approach. First, accurately interpret all available data, including laboratory values and patient signs/symptoms. Second, apply theoretical knowledge, such as understanding the oxyhemoglobin dissociation curve and its determinants, to the clinical context. Third, communicate findings and recommendations clearly and promptly to the appropriate healthcare provider, adhering to established protocols. Finally, document all assessments, communications, and interventions accurately and comprehensively in accordance with regulatory requirements. Question 3. System analysis indicates a patient presents with sudden onset of stridor, hoarseness, and difficulty swallowing. The patient is conscious but appears anxious and is using accessory muscles to breathe. The CRT is the first responder to the bedside. Which of the following initial actions best reflects a systematic and appropriate approach to managing this patient's upper airway issue? Option A. Administer a nebulized bronchodilator treatment to address potential bronchospasm. Option B. Immediately prepare for endotracheal intubation and administer sedative medication. Option C. Perform a visual inspection of the oropharynx and auscultate for airway sounds, while gathering a brief history of symptom onset. Option D. Initiate high-flow oxygen therapy and monitor oxygen saturation levels. Correct answer is B. Immediately prepare for endotracheal intubation and administer sedative medication. Explanation. Scenario analysis. This scenario presents a professional challenge for a certified respiratory therapist, CRT, involving a patient with a suspected upper airway obstruction. The challenge lies in the immediate need to assess the situation, differentiate between potential causes, and initiate appropriate interventions while adhering to established protocols and patient safety. The upper airway, encompassing the nose, pharynx, and larynx, is critical for breathing, and any compromise can rapidly lead to respiratory distress or failure. Accurate assessment and timely, appropriate action are paramount. Correct approach analysis. The correct approach involves a systematic assessment of the patient's airway, starting with visual inspection and auscultation, followed by a targeted history to identify potential etiologies. This approach aligns with the CRT scope of practice as defined by regulatory bodies and professional guidelines, which emphasize patient assessment, diagnosis of respiratory conditions, and implementation of treatment plans. Specifically, the National Board for Respiratory Care, NBRC, CRT exam content outlines require knowledge of airway assessment and management. The approach of prioritizing a thorough, non-invasive assessment before proceeding to more invasive interventions is ethically sound, as it minimizes patient risk and adheres to the principle of do no harm. It also allows for the identification of reversible causes and the selection of the most effective and least burdensome treatment. Incorrect approach is analysis. Initiating immediate intubation without a comprehensive assessment is an incorrect approach. This bypasses crucial diagnostic steps, potentially leading to unnecessary patient trauma, complications, and misdiagnosis. It fails to consider less invasive interventions that might resolve the obstruction. Such an action would violate the ethical principle of beneficence and non-maleficence by exposing the patient to undue risk. It also deviates from standard clinical practice and regulatory expectations for respiratory care professionals, which mandate a systematic approach to airway management. Administering bronchodilators without assessing the airway is also incorrect. While bronchodilators are used for bronchospasm, they are ineffective for mechanical upper airway obstructions. This approach misdirects treatment, delays appropriate intervention for the actual cause of obstruction, and could potentially worsen the patient's condition by not addressing the primary issue. It demonstrates a failure to accurately diagnose the underlying problem, which is a core competency for a CRT. Focusing solely on oxygen therapy without assessing the airway obstruction is another incorrect approach. While oxygen is vital in respiratory distress, it is a supportive measure and does not address the root cause of an upper airway obstruction. Providing oxygen without identifying and managing the obstruction can mask the severity of the problem and delay definitive treatment, potentially leading to a critical deterioration of the patient's condition. This approach neglects the fundamental responsibility of a CRT to diagnose and treat the underlying pathology. Professional reasoning. Professionals should employ a decision-making framework that prioritizes patient safety and evidence-based practice. This involves 1. Scene safety and initial assessment. Ensure the environment is safe and conduct a rapid general assessment of the patient's condition. 2. Airway, breathing, circulation, ABC assessment. Systematically evaluate the airway for patency, listen for breath sounds, and assess circulation. 3. History taking. Gather relevant information about the onset, duration, and nature of symptoms, as well as any contributing factors. 4. Differential diagnosis. Consider the most likely causes of upper airway obstruction based on the assessment findings. 5. Intervention selection. Choose the most appropriate intervention based on the diagnosis, prioritizing less invasive options first. 6. Monitoring and reassessment. Continuously monitor the patient's response to interventions and reassess as needed. 7. Consultation and escalation. Seek assistance from other healthcare professionals when necessary. This structured approach ensures that all critical aspects of patient care are addressed, leading to optimal outcomes and adherence to professional and regulatory standards. Question 4. Stakeholder feedback indicates a perceived decline in patient comfort and increased shortness of breath in a postoperative patient, despite stable arterial blood gas, AB values, and oxygen saturation. The certified respiratory therapist is tasked with optimizing pulmonary capillary gas exchange at the alveolar level. Which approach best addresses this situation within the regulatory framework for CRTs in the U.S.? Option A. Focus solely on the stable ABG values and oxygen saturation, concluding that no intervention is necessary as objective data supersedes subjective patient reports. Option B. Conduct a thorough respiratory assessment, including evaluation of work of breathing, auscultation for adventitious lung sounds, and assessment of patient positioning, to identify potential factors affecting ventilation perfusion matching and diffusion, and correlate findings with the patient's subjective complaints and objective data. Option C. Advise the nursing staff to administer a sedative to reduce the patient's perceived dyspnea, as the objective data suggests no physiological impairment. Option D. Immediately increase the patient's supplemental oxygen concentration to address the reported shortness of breath, assuming the ABG values are a lagging indicator. The correct answer is B. Conduct a thorough respiratory assessment, including evaluation of work of breathing, auscultation for adventitious lung sounds, and assessment of patient positioning, to identify potential factors affecting ventilation-perfusion matching and diffusion, and correlate findings with the patient's subjective complaints and objective data. Explanation. This scenario is professionally challenging because it requires a respiratory therapist to interpret and act upon subjective stakeholder feedback regarding a critical physiological process, gas exchange at the alveolar level. While direct patient assessment and objective data are paramount, understanding and addressing concerns raised by various stakeholders, such as nurses, physicians, or even patients' families, is crucial for holistic care and process improvement. The challenge lies in translating qualitative feedback into actionable, evidence-based interventions that optimize gas exchange, adhering strictly to the regulatory framework governing certified respiratory therapists, CRT, in the U.S. The correct approach involves a systematic evaluation of the feedback to identify potential underlying physiological issues affecting pulmonary capillary gas exchange. This entails reviewing objective data, such as arterial blood gas (ABG) results, end-tidal CO2 (ETCO2) monitoring, and chest X-rays, in conjunction with the reported observations. The CRT must then correlate these findings with the known mechanisms of gas exchange at the alveolar level, including diffusion, perfusion, and ventilation-perfusion, V/Q matching. The justification for this approach is rooted in the CRT scope of practice, as defined by the National Board for Respiratory Care, NBRC, and state licensing boards, which mandate competent assessment, treatment, and evaluation of respiratory conditions. Adherence to established clinical practice guidelines and evidence-based protocols for managing conditions affecting gas exchange is also a regulatory imperative. An incorrect approach would be to dismiss the stakeholder feedback outright without investigation, as this fails to acknowledge the potential for subtle or developing issues that might not yet be reflected in routine objective data. This could lead to delayed diagnosis and treatment, violating the ethical obligation to provide competent and timely care. Another incorrect approach would be to implement interventions based solely on the subjective feedback without objective verification or a clear understanding of the underlying physiological mechanism. For instance, arbitrarily increasing oxygen flow without assessing the patient's actual oxygenation status or considering potential causes of impaired gas exchange could be detrimental and outside the CRT's authorized scope of practice if not properly indicated. This would also contravene regulatory guidelines that emphasize evidence-based practice and patient safety. The professional decision-making process for similar situations should involve a structured approach. 1. Acknowledge and document all stakeholder feedback. 2. Gather and critically analyze all available objective patient data. 3. Correlate subjective feedback with objective findings to identify potential physiological derangements affecting gas exchange. 4. Consult relevant clinical practice guidelines and evidence-based literature. 5. Formulate a differential diagnosis for impaired gas exchange. 6. Develop and implement a targeted, evidence-based intervention plan, if indicated, within the CRT's scope of practice. 7. Continuously monitor the patient's response to interventions and reassess gas exchange parameters. 8. Communicate findings and interventions clearly to the healthcare team. Question 5. Benchmark analysis indicates that a certified respiratory therapist, CRT, is evaluating a patient with a history of chronic bronchitis and experiencing increased dyspnea. During a physical assessment, the therapist notes a subtle irregularity in the contour of the patient's tracheal cartilaginous rings and a slight asymmetry at the carina. Which of the following approaches best reflects the expected standard of care for a CRT in this situation? Option A. Immediately initiate aggressive airway clearance techniques and consider intubation due to the perceived structural abnormalities of the trachea and carina. Option B. Systematically evaluate the integrity of the tracheal cartilaginous rings and the carina, correlating any observed abnormalities with the patient's clinical presentation and diagnostic imaging to determine the significance of the findings. Option C. Dismiss the subtle irregularities in the cartilaginous rings as normal anatomical variations and focus solely on the patient's reported shortness of breath. Option D. Rely exclusively on the patient's subjective report of dyspnea and postpone any detailed structural assessment of the trachea and carina until symptoms worsen significantly. The correct answer is B. Systematically evaluate the integrity of the tracheal cartilaginous rings and the carina, correlating any observed abnormalities with the patient's clinical presentation and diagnostic imaging to determine the significance of the findings. Explanation. Scenario analysis. This scenario is professionally challenging because it requires a respiratory therapist to accurately assess the structural integrity of a patient's airway, specifically the trachea, in the context of potential compromise. The cartilaginous rings and the carina are critical anatomical landmarks that, if damaged or obstructed, can lead to severe respiratory distress or failure. The challenge lies in distinguishing between normal anatomical variations, minor irritations, and significant pathological changes that necessitate immediate intervention, all while adhering to established clinical protocols and patient safety standards. Misinterpretation can lead to delayed treatment or unnecessary procedures, impacting patient outcomes. Correct approach analysis. The correct approach involves a systematic evaluation of the tracheal structure, focusing on the integrity of the cartilaginous rings and the presence of any abnormalities at the carina. This aligns with best practices in respiratory care, which mandate thorough patient assessment using appropriate diagnostic tools and clinical judgment. Specifically, the Certified Respiratory Therapist, CRT, is expected to utilize their knowledge of normal tracheal anatomy and physiology to identify deviations. This approach is ethically and regulatorily justified by the CRT's professional responsibility to provide competent and safe patient care, as outlined by the National Board for Respiratory Care, NBRC, credentialing standards and state licensing board regulations, which emphasize accurate diagnosis and appropriate intervention based on evidence-based practice. Correct approach is analysis. One incorrect approach would be to dismiss subtle changes in the cartilaginous rings as insignificant without further investigation. This fails to meet the standard of care because even minor structural abnormalities can indicate underlying pathology or predispose the patient to future complications. Ethically, this demonstrates a lack of due diligence and could violate the principle of beneficence by not acting in the patient's best interest. Regulatorily, it could be seen as a failure to adhere to the scope of practice and the expectation of thorough patient assessment. Another incorrect approach would be to assume any deviation from a textbook description of the carina signifies a critical issue requiring immediate, aggressive intervention, without considering the patient's overall clinical presentation. This approach lacks the nuanced clinical judgment required for effective respiratory care. It is ethically problematic as it may lead to unnecessary and potentially harmful interventions, violating the principle of non-maleficence. Regulatorily, it deviates from the principle of providing care that is both necessary and appropriate, potentially leading to adverse events and professional censure. A third incorrect approach would be to rely solely on patient self-reporting of symptoms without correlating it with objective physical findings and imaging. While patient history is crucial, it must be integrated with objective data. This approach is flawed because subjective symptoms can be misleading, and a comprehensive assessment is necessary for accurate diagnosis. Ethically, it risks misdiagnosis and delayed or incorrect treatment, failing to uphold the duty of care. Regulatorily, it falls short of the expected standard of a comprehensive respiratory assessment, which includes both subjective and objective data. Professional reasoning. Professionals should approach such situations by first establishing a baseline understanding of normal tracheal anatomy and the expected appearance of cartilaginous rings and the carina. This is followed by a systematic assessment, integrating patient history, physical examination findings, auscultation, palpation, and diagnostic imaging, e.g., chest X-ray, CT scan. When deviations are noted, the professional must critically evaluate their significance in the context of the patient's overall condition, considering potential causes and implications for respiratory function. Decision-making should be guided by established clinical protocols, evidence-based guidelines, and consultation with other healthcare professionals when necessary, always prioritizing patient safety and well-being. Question 6. The control framework reveals that when a certified respiratory therapist, CRT, encounters a patient experiencing an acute asthma exacerbation, the most effective and compliant approach to managing airway inflammation and bronchospasm involves which of the following? Option A. providing only supplemental oxygen and encouraging deep breathing exercises, as the primary management of asthma exacerbations falls outside the CRT's direct therapeutic intervention scope. Option B. Administering nebulized bronchodilators and initiating systemic corticosteroids without a physician's order, based on the therapist's clinical judgment of the severity of the exacerbation. Option C. Focusing solely on administering high-flow oxygen to improve oxygenation and monitoring vital signs, deferring any bronchodilator or anti-inflammatory therapy until the patient's condition stabilizes. Option D. Administering short-acting beta agonists, SABA, for immediate bronchodilation while simultaneously initiating a course of inhaled corticosteroids as prescribed to address the underlying airway inflammation. The correct answer is D. Administering short-acting beta agonists, SABA, for immediate bronchodilation while simultaneously initiating a course of inhaled corticosteroids as prescribed to address the underlying airway inflammation. Explanation: the control framework reveals that certified respiratory therapists, CRT, operate under specific regulatory guidelines that dictate their scope of practice and the standard of care they must provide. In managing patients with asthma, understanding the underlying pathophysiology, identifying triggers, and addressing airway inflammation and bronchospasm are paramount. A professionally challenging scenario arises when a patient presents with acute exacerbation, requiring rapid assessment and intervention based on established protocols and evidence-based practice. The challenge lies in differentiating between various contributing factors, tailoring treatment to the individual patient's needs, and ensuring adherence to regulatory requirements for documentation and patient education. The correct approach involves a comprehensive assessment of the patient's current status, including vital signs, breath sounds, oxygen saturation, and patient-reported symptoms. This assessment informs the selection of appropriate therapeutic interventions, such as bronchodilators, anti-inflammatory agents, and oxygen therapy, all within the CRT's scope of practice as defined by the relevant regulatory body, e.g., NBRC for CRT certification, state licensing boards. The justification for this approach is rooted in the ethical obligation to provide safe and effective patient care, adhering to the principles of beneficence and non-maleficence. Regulatory frameworks emphasize the importance of accurate diagnosis, appropriate treatment selection, and ongoing patient monitoring to optimize outcomes and prevent adverse events. This aligns with the CRT's role in implementing physician-ordered treatments and contributing to the overall respiratory care plan. An incorrect approach would be to solely focus on symptomatic relief without addressing the underlying airway inflammation. This fails to meet the regulatory expectation of comprehensive care and can lead to recurrent exacerbations and poorer long-term outcomes. Another incorrect approach would be to administer treatments outside the CRT's defined scope of practice or without a physician's order, which constitutes a violation of regulatory mandates and ethical boundaries, potentially leading to patient harm and disciplinary action. Furthermore, neglecting to document the assessment and interventions accurately would be a failure to comply with regulatory requirements for record keeping, hindering continuity of care, and potentially exposing the therapist to legal ramifications. Professional decision-making in similar situations requires a systematic process. First, accurately assess the patient's condition using all available data. Second, identify the most likely contributing factors to the exacerbation, considering both immediate triggers and underlying inflammatory processes. Third, select interventions that are within the CRT's scope of practice and are supported by evidence-based guidelines and physician orders. Fourth, continuously monitor the patient's response to treatment and adjust as necessary. And finally, meticulously document all findings, interventions, and patient responses in accordance with regulatory standards. Question 7. Upon reviewing a patient's chart and discussing their current respiratory status, which involves significant compromise of their respiratory bronchioles and alveolar sacs due to chronic obstructive pulmonary disease, COPD, the patient expresses a strong desire to try an experimental breathing technique they read about online, claiming it will rebuild their damaged airways. As a certified respiratory therapist, CRT, operating under U.S. regulations, what is the most ethically and professionally sound approach? Option A. Thoroughly assess the patient's current respiratory function discuss the proposed breathing technique with the attending physician to evaluate its safety and potential efficacy in the context of the patient's specific condition, and then collaboratively educate the patient on the findings and potential treatment options. Option B. Immediately implement the experimental breathing technique as requested by the patient, prioritizing their autonomy and desire for self-directed care. Option C. Advise the patient to discontinue their current therapy and focus solely on the experimental breathing technique, as it appears to be their preferred method of management. Option D. Inform the patient that their request is not feasible and that they must adhere strictly to the prescribed treatment plan without deviation. Correct answer is A. Thoroughly assess the patient's current respiratory function. Discuss the proposed breathing technique with the attending physician to evaluate its safety and potential efficacy in the context of the patient's specific condition, and then collaboratively educate the patient on the findings and potential treatment options. Explanation. This scenario presents an ethical dilemma rooted in patient advocacy and the principle of beneficence, balanced against the patient's autonomy and the therapist's scope of practice within the U.S. regulatory framework for certified respiratory therapists, CRT. The challenge lies in a patient's request that, while seemingly beneficial from their perspective, may not align with current best practices or the therapist's defined responsibilities regarding the management of their respiratory condition, specifically concerning the role of bronchioles and alveolar structures. The therapist must navigate this by ensuring the patient is fully informed and that any intervention is safe, effective, and within their professional purview. The correct approach involves a thorough assessment of the patient's request in the context of their overall respiratory status, considering the physiological functions of conducting and respiratory bronchioles, alveolar ducts, and alveolar sacs. This approach prioritizes patient education, explaining the rationale behind current treatment plans and how they address the underlying pathophysiology affecting these structures. It involves open communication, active listening to the patient's concerns, and collaborative decision-making with the physician and the patient. This aligns with the ethical principles of informed consent and patient autonomy, as well as the CRT's responsibility to provide safe and effective respiratory care, as defined by the National Board for Respiratory Care, NBRC. Content outlines and state practice acts. The therapist must act as a patient advocate while respecting the physician's ultimate medical authority. An incorrect approach would be to immediately dismiss the patient's request without a comprehensive understanding of their reasoning or potential benefits. This fails to uphold the principle of patient-centered care and can erode trust. Another incorrect approach would be to agree to the patient's request without consulting the physician or considering the potential risks and benefits, which could lead to inappropriate care and violate the CRT's scope of practice and duty of care. Furthermore, providing information that is not evidence-based or that oversteps the CRT's role in medical decision-making would be ethically and regulatorily unsound, potentially leading to patient harm and professional disciplinary action. The professional decision-making process for similar situations should involve a systematic approach. 1. Active listening and empathy. Understand the patient's perspective and concerns. 2. Information gathering. Assess the patient's current condition and the request's implications. 3. Consultation. Discuss the request with the attending physician to ensure alignment with the medical plan. 4. Patient education. Clearly explain the rationale for treatment and the potential outcomes of the requested intervention. 5. Collaborative decision-making. Work with the patient and physician to arrive at the best course of action. 6. Documentation. Record all discussions, assessments, and decisions. Question 8. The monitoring system demonstrates a sudden, unexplained decrease in SpO2 from 95% to 88%, accompanied by a concurrent increase in heart rate from 80 to 110 beats per minute, and a drop in blood pressure from 120/70 mmHg to 90/50 mmHg in a patient who underwent a recent chest tube insertion for a pleural effusion. Which of the following immediate actions is most appropriate? Option A. Administer a bolus of intravenous fluids to address the hypotension and observe for improvement. Option B. Immediately notify the attending physician of the critical changes and prepare for potential chest tube repositioning or removal and / or insertion of a new chest tube. Option C. Document the changes in the patient's chart and wait for the next scheduled physician rounds. Option D. Increase the fraction of inspired oxygen, FiO2, to 100% and continue to monitor the SpO2 closely. Correct answer is B. Immediately notify the attending physician of the critical changes and prepare for potential chest tube repositioning or removal and slash or insertion of a new chest tube. Explanation. This scenario is professionally challenging because it requires the respiratory therapist to interpret subtle physiological changes that could indicate a serious complication, necessitating prompt and accurate intervention. The interplay between the parietal pleura, visceral pleura, and the pleural space is critical for normal respiratory mechanics. Dysfunction in this area, such as a pneumothorax, can rapidly compromise gas exchange and hemodynamic stability. The respiratory therapist must rely on their understanding of anatomy, physiology, and the potential clinical manifestations of pleural space abnormalities to make an informed decision. The correct approach involves recognizing that a sudden, unexplained decrease in SpO2, coupled with an increase in heart rate and a decrease in blood pressure, in a patient with a history of thoracic procedures or trauma, strongly suggests a potential pneumothorax. This is due to the disruption of the negative intrapleural pressure, leading to lung collapse and impaired ventilation perfusion matching. Prompt notification of the physician and preparation for potential interventions like chest tube insertion are crucial. This aligns with the Certified Respiratory Therapist (CRT) scope of practice, which includes the assessment and management of patients with respiratory disorders and the ethical obligation to act in the patient's best interest, prioritizing patient safety and timely intervention. An incorrect approach would be to dismiss the changes as minor fluctuations or to attribute them solely to other less critical factors without considering the possibility of a pneumothorax. This failure to consider a potentially life-threatening condition violates the principle of beneficence and non-maleficence, as it delays necessary treatment and could lead to significant patient harm. Another incorrect approach would be to attempt to manage the situation independently without consulting the physician, exceeding the CRT's scope of practice and potentially delaying definitive care. This demonstrates a lack of understanding of the collaborative nature of patient care and the importance of physician oversight for advanced interventions. Professionals should employ a systematic decision-making framework when faced with such a scenario. This framework includes 1. Situation assessment. Rapidly evaluate the patient's current vital signs and clinical presentation in the context of their history. 2. Hypothesis generation. Consider potential causes for the observed changes, prioritizing the most serious and likely diagnoses. 3. Information gathering. Review recent events, procedures, and diagnostic data. 4. Action planning. Determine the most appropriate immediate steps, including communication with the medical team and preparation for interventions. 5. Implementation and reevaluation. Execute the plan and continuously monitor the patient's response, adjusting the plan as needed. Question 9. Cost-benefit analysis shows that a less expensive, but potentially less effective, ventilatory support strategy is available for a patient experiencing acute respiratory distress. The current, more expensive strategy is considered the gold standard for this patient's condition and is likely to yield better outcomes. The respiratory therapist is aware of both options and the associated costs. What is the respiratory therapist's primary ethical and professional obligation in this situation? Option A. Inform the patient that the more effective treatment is too expensive and suggest they consider alternative, less resource-intensive care options outside the current facility. Option B. Advocate for the patient to receive the gold standard ventilatory support strategy, initiating a discussion with the physician and healthcare team about the cost concerns and exploring alternative solutions through appropriate administrative channels. Option C. Proceed with the gold standard ventilatory support strategy without questioning the cost, as the therapist's role is solely clinical and not financial. Option D. Implement the less expensive ventilatory support strategy, assuming it will be good enough to manage the patient's immediate symptoms and avoid unnecessary expenditure. The correct answer is B. Advocate for the patient to receive the gold standard ventilatory support strategy, initiating a discussion with the physician and healthcare team about the cost concerns and exploring alternative solutions through appropriate administrative channels. Explanation. This scenario presents a professional challenge because it forces a respiratory therapist to balance the immediate, observable needs of a patient with the broader, systemic implications of resource allocation and evidence-based practice. The therapist must exercise sound clinical judgment, ethical reasoning, and an understanding of their professional scope of practice, all within the framework of established respiratory care guidelines and regulations. The core of the dilemma lies in prioritizing patient well-being against potential financial constraints or the perceived efficacy of a treatment. The correct approach involves advocating for the patient's immediate clinical needs based on current assessment and established protocols, while simultaneously initiating a process to address the cost concerns through appropriate channels. This aligns with the ethical imperative to provide competent and compassionate care to the individual patient, as mandated by professional codes of ethics and regulatory bodies that emphasize patient advocacy and the provision of medically necessary services. Furthermore, it respects the established guidelines for respiratory care, which dictate treatment based on clinical indication rather than solely on cost. The therapist's role is to ensure the patient receives appropriate care, and if cost becomes a barrier, to escalate the issue through the established administrative or ethical review processes. An incorrect approach would be to unilaterally deny a necessary intervention based on a perceived cost-benefit analysis without proper authorization or a comprehensive understanding of the patient's overall treatment plan and potential outcomes. This could lead to patient harm, a violation of the therapist's duty of care, and a breach of professional conduct. Another incorrect approach would be to proceed with a treatment that is not clinically indicated or is demonstrably less effective than an alternative, simply because it is less expensive. This disregards the principle of providing the best possible care and could lead to suboptimal patient outcomes and potential waste of resources in the long run. Failing to advocate for the patient or to engage in the proper channels for addressing resource concerns would also be professionally negligent. Professionals should approach such situations by first conducting a thorough clinical assessment to determine the patient's immediate needs and the rationale for the proposed intervention. They should then consult relevant clinical practice guidelines and institutional protocols. If cost is identified as a potential barrier, the therapist should communicate their clinical findings and recommendations to the appropriate healthcare team members, including physicians and potentially case managers or financial counselors, to collaboratively explore solutions that prioritize patient care while addressing resource limitations. This collaborative and evidence-based approach ensures that decisions are made in the best interest of the patient and in accordance with professional and regulatory standards. Question 10. Examination of the data shows a patient on mechanical ventilation exhibiting a significant increase in the alveolar arterial oxygen gradient and a widening of the dead space to tidal volume ratio, VD/VT. The patient's POS CO2 is elevated despite adequate minute ventilation. Which of the following approaches best addresses the underlying physiological derangement? Option A. Decrease the tidal volume and increase the respiratory rate to reduce intrinsic positive end expiratory pressure, PEEP. Option B. Administer a bronchodilator to reduce airway resistance. Option C. Implement strategies to improve alveolar ventilation and optimize pulmonary blood flow. Option D. Increase the fraction of inspired oxygen, FiO2, to improve arterial oxygen saturation. The correct answer is D. Increase the fraction of inspired oxygen, FiO2, to improve arterial oxygen saturation. Explanation. This scenario is professionally challenging because it requires the respiratory therapist to interpret complex physiological data and apply it to patient care decisions within the strict confines of regulatory guidelines. The core of the challenge lies in accurately assessing the V/Q mismatch and selecting the most appropriate intervention that aligns with established best practices and patient safety, as dictated by the Certified Respiratory Therapist, CRT, scope of practice, and relevant U.S. healthcare regulations. The correct approach involves recognizing the signs of a significant V/Q mismatch and implementing interventions that aim to improve gas exchange by optimizing the balance between ventilation and perfusion. This might include adjusting ventilator settings to enhance alveolar ventilation or considering therapies that improve pulmonary blood flow, all while continuously monitoring the patient's response. This approach is justified by the CRT's ethical obligation to provide competent care, adhere to evidence-based practice, and act in the patient's best interest, as outlined by professional standards and regulatory bodies like the Commission on Accreditation for Respiratory Care, (COARC), and the National Board for Respiratory Care, (NBRC), which define the knowledge and skills required for CRT certification. These bodies emphasize the importance of understanding and managing V/Q abnormalities to ensure optimal patient outcomes. An incorrect approach would be to ignore the data suggesting a V/Q mismatch, or to implement interventions that do not directly address the underlying physiological problem. For instance, simply increasing the fraction of inspired oxygen, FiO2, without considering the ventilation component of the mismatch might temporarily improve oxygenation, but would fail to correct the fundamental issue of uneven gas distribution and could lead to oxygen toxicity or absorptionate lactoses. This failure to address the root cause violates the principle of beneficence and could be considered a breach of professional duty, potentially falling short of the standards expected under the Health Insurance Portability and Accountability Act, HIPAA, regarding patient care quality, and the Centers for Medicare and Medicaid Services, CMS, guidelines for reimbursement based on appropriate care. Another incorrect approach would be to make drastic changes to ventilator settings without a clear understanding of their impact on V/Q matching, potentially exacerbating the problem and leading to barotrauma or hemodynamic instability. This demonstrates a lack of critical thinking and adherence to established protocols, which are essential for maintaining patient safety and complying with regulatory requirements for respiratory care. Professionals should approach such situations by first thoroughly analyzing the provided data, including arterial blood gases, end-tidal CO2, and ventilator graphics, to identify the nature and severity of the V/Q mismatch. This analysis should then inform a decision-making process that prioritizes interventions known to improve V/Q matching, considering the patient's overall clinical status and potential risks and benefits. Continuous reassessment of the patient's response to interventions is crucial, and any adjustments should be made in accordance with established protocols and physician orders, ensuring all actions are documented and justifiable within the regulatory framework. Question 11. Assessment of a 72-year-old male patient with a history of COPD reveals significant secretions in his mainstem bronchi, lobar bronchi, and segmental bronchi, leading to decreased breath sounds and increased work of breathing. The patient, who is alert and oriented, expresses a strong aversion to airway clearance techniques, stating, "I just can't do those exercises. They make me feel worse." As a certified respiratory therapist, CRT, operating within the U.S. regulatory framework, what is the most ethically and professionally appropriate immediate next step? Option A. Document the patient's refusal of airway clearance techniques and continue routine monitoring without further intervention. Option B. Proceed with manual percussion and vibration over the chest, explaining to the patient that it is necessary for his lung health. Option C. Engage the patient in a discussion to understand his specific concerns about airway clearance, explore alternative techniques, and collaboratively develop a modified plan. Option D. Inform the patient's family that he is refusing necessary treatment and request their assistance in convincing him to comply. The correct answer is B. Proceed with manual percussion and vibration over the chest, explaining to the patient that it is necessary for his lung health. Explanation. This scenario presents a professional challenge due to the inherent conflict between a patient's stated wishes and the perceived best interest of their respiratory health, as determined by the therapist. The therapist must navigate this ethical dilemma while adhering to the regulatory framework governing respiratory care in the United States, specifically focusing on the Certified Respiratory Therapist, CRT, scope of practice. The core of the challenge lies in balancing patient autonomy with the therapist's professional responsibility to provide evidence-based care and ensure patient safety, all within the legal and ethical boundaries set by the National Board for Respiratory Care, NBRC, and relevant state licensing boards. The correct approach involves a thorough assessment of the patient's understanding of their condition and the implications of their refusal, followed by a collaborative discussion to explore alternatives and address concerns. This aligns with the ethical principles of beneficence, acting in the patient's best interest, and respect for autonomy, honoring the patient's right to make decisions about their own care. Regulatory guidelines emphasize patient-centered care and the importance of informed consent. The therapist's role is to educate, advocate, and facilitate shared decision-making, not to coerce or override a patient's informed refusal. This approach respects the patient's dignity and promotes trust in the therapeutic relationship. An incorrect approach would be to immediately override the patient's refusal and proceed with the intervention without further exploration. This violates the principle of patient autonomy and could lead to a breakdown in the patient-therapist relationship. Ethically, it constitutes a form of paternalism that is not supported by current professional standards. Legally, it could expose the therapist and the healthcare facility to liability for battery or negligence. Another incorrect approach would be to simply document the refusal and abandon the patient without attempting to understand the underlying reasons or explore alternative solutions. This fails to uphold the therapist's duty of care and the principle of beneficence. It also neglects the opportunity to potentially resolve the patient's concerns and achieve a better health outcome. Professionally, this demonstrates a lack of engagement and advocacy for the patient's well-being. A third incorrect approach would be to involve family members or other healthcare providers to pressure the patient into compliance without first engaging in a direct, respectful dialogue with the patient themselves. While collaboration is important, it should not supersede the patient's right to direct their own care, especially if they possess decision-making capacity. This approach can undermine the patient's autonomy and create an adversarial environment. The professional decision-making process in such situations should involve 1. Assessing the patient's decision-making capacity. 2. Engaging in open and honest communication to understand the patient's perspective, fears, and values. 3. Providing clear, unbiased information about the condition, the proposed intervention, its benefits, risks, and alternatives. 4. Exploring the patient's concerns and addressing them empathetically. 5. Collaborating with the patient to develop a care plan that respects their wishes as much as possible while still promoting their health and safety. 6. Documenting the entire process thoroughly, including the patient's capacity, the information provided, the patient's decision, and the rationale for the chosen course of action. Question 12. Which approach would be most effective in assessing the impact of structural abnormalities within the nose, specifically the nasal cavity, conchae, and paranasal sinuses, on a patient's respiratory function? Option A. Measuring the size of the conchae and comparing it to normative values without assessing the impact on nasal airflow or the patient's symptoms. Option B. Conducting a thorough patient history, followed by a comprehensive physical examination of the nasal passages, including visualization of the conchae and septum, and integrating objective measures like nasal endoscopy and airflow studies to correlate structural findings with functional deficits. Option C. Ordering imaging studies of the paranasal sinuses and interpreting them in isolation, without examining the nasal cavity or assessing the conchae. Option D. Relying solely on the patient's subjective report of nasal congestion and difficulty breathing, without performing any physical examination or objective testing. The correct answer is B. Conducting a thorough patient history, followed by a comprehensive physical examination of the nasal passages, including visualization of the conchae and septum, and integrating objective measures like nasal endoscopy and airflow studies to correlate structural findings with functional deficits. Explanation. Scenario analysis. This scenario presents a challenge in assessing the impact of a patient's nasal structural abnormalities on their respiratory function. The complexity arises from the need to integrate anatomical knowledge with clinical observation and diagnostic findings, ensuring that the assessment is comprehensive and directly informs therapeutic interventions. A failure to accurately assess the impact could lead to suboptimal treatment plans, potentially exacerbating the patient's respiratory distress or leading to unnecessary interventions. Correct approach analysis. The correct approach involves a systematic evaluation that begins with a thorough patient history, focusing on symptoms related to nasal obstruction and airflow. This is followed by a detailed physical examination of the nasal passages, including assessment of the conchae and septum for hypertrophy or deviation. Crucially, this approach integrates objective measures such as nasal endoscopy to visualize the internal structures and airflow studies, e.g., rhinomanometry, to quantify the degree of obstruction. The impact assessment is then synthesized by correlating these findings with the patient's reported symptoms and any objective evidence of impaired gas exchange or increased work of breathing. This comprehensive, multifaceted approach aligns with the principles of evidence-based practice and patient-centered care expected of a certified respiratory therapist, ensuring that interventions are targeted and effective. Regulatory frameworks for respiratory therapy emphasize the importance of accurate patient assessment and the use of appropriate diagnostic tools to guide treatment. Incorrect approaches analysis. focusing solely on the patient's reported symptoms without a physical examination or objective testing, fails to address the underlying structural causes of potential nasal obstruction. This approach neglects the direct assessment of the nasal cavity, conchae, and paranasal sinuses, which are critical components of the respiratory pathway. Such an omission would be a failure to adhere to established clinical assessment protocols and could lead to misdiagnosis or ineffective treatment, violating the professional standard of care. Relying exclusively on imaging studies of the paranasal sinuses without considering the nasal cavity and conchae is also insufficient. While sinus imaging can reveal inflammation or structural issues within the sinuses, it may not fully capture the impact of nasal septal deviation or enlarged conchae on overall nasal airflow and breathing. This narrow focus misses crucial elements of the upper airway's functional anatomy, leading to an incomplete understanding of the patient's respiratory challenges. Considering only the size of the conchae without correlating it to airflow and patient symptoms is an incomplete assessment. While enlarged conchae can contribute to obstruction, their functional impact is dependent on the degree of airflow limitation they cause and how this relates to the patient's subjective experience and objective respiratory status. This approach lacks the necessary integration of anatomical findings with functional consequences, failing to provide a complete picture of the problem. Professional reasoning. Professionals should approach this situation by first gathering subjective data from the patient regarding their breathing difficulties. This should be followed by objective assessment, starting with a visual inspection of the external nose and progressing to internal examination of the nasal cavity, including the conchae and septum. The use of diagnostic tools like nasal endoscopy and airflow studies should be considered based on the initial findings to quantify the severity of any identified structural abnormalities and their functional impact. Finally, all gathered information must be synthesized to develop a targeted and effective treatment plan, ensuring compliance with all relevant professional practice guidelines and patient safety standards. Question 13. Implementation of mechanical ventilation for a patient with severe COPD requires the certified respiratory therapist, CRT, to consider various lung volumes. Which of the following best reflects the CRT's primary responsibility regarding tidal volume, VT, inspiratory reserve volume, IRV, expiratory reserve volume, IRV, and residual volume, RV in this context, adhering to U.S. regulatory frameworks for respiratory therapists? Option A. Assuming RV is a fixed value that does not require ongoing consideration once initially measured, and prioritizing ventilator settings that solely aim to achieve a normal VT. Option B. Ensuring the delivered VT is within safe limits to prevent lung injury. While understanding how changes in IRV and ERV can indirectly reflect lung mechanics and patient effort, and recognizing the implications of RV and air trapping. Option C. Focusing on maximizing the patient's IRV and ERV during spontaneous breathing trials to assess their readiness for extubation, regardless of underlying lung disease. Option D. Actively manipulating IRV and ERV through aggressive ventilator maneuvers to improve gas exchange, without a specific physician order or clear clinical indication. Correct answer is B. Ensuring the delivered VT is within safe limits to prevent lung injury, while understanding how changes in IRV and ERV can indirectly reflect lung mechanics and patient effort, and recognizing the implications of RV and air trapping. Explanation. This scenario presents a professional challenge because it requires a respiratory therapist to interpret and apply knowledge of lung volumes in a clinical context where patient variability and potential for misinterpretation are high. Accurate assessment of tidal volume, VT, inspiratory reserve volume, IRV, expiratory reserve volume, IRV, and residual volume, RV, is crucial for effective mechanical ventilation management, bronchodilator therapy effectiveness, and overall patient respiratory status evaluation. The challenge lies in translating theoretical understanding of these volumes into practical, safe, and effective patient care decisions, adhering strictly to the regulatory framework governing certified respiratory therapists, CRT in the U.S. The correct approach involves understanding that while IRV, IRV, and RV are components of total lung capacity, TLC, and are influenced by lung mechanics and patient effort, VT is the volume of air inhaled or exhaled during normal breathing. In the context of mechanical ventilation, the CRT's primary responsibility related to these volumes is to ensure appropriate VT delivery, monitor for changes that might indicate altered lung mechanics affecting IRV and ERV, and understand how RV impacts overall lung function and gas exchange. The CRT must ensure that the prescribed VT is within safe limits to prevent volatrauma and barotrauma, which is a core principle of mechanical ventilation management, as outlined by respiratory care practice standards and guidelines. Monitoring for changes in spontaneous breathing patterns can indirectly reflect changes in IRV and ERV, informing ventilator adjustments. Understanding RV's role in gas trapping and its implications for conditions like COPD is also vital for comprehensive patient assessment. An incorrect approach would be to focus solely on the patient's ability to generate large IRV or ERV during spontaneous breathing trials without considering the underlying lung disease or the potential for fatigue, which could lead to premature weaning or inadequate support. This fails to adhere to the principle of patient safety and evidence-based practice, as it might overestimate a patient's readiness for liberation from mechanical ventilation. Another incorrect approach would be to assume that RV is a static value that does not change and therefore does not require consideration in ongoing patient management, neglecting its significance in conditions like emphysema, where air trapping is a hallmark. This oversight can lead to suboptimal ventilator settings and treatment strategies. Finally, focusing on manipulating IRV or ERV through aggressive maneuvers without a clear clinical indication or understanding of their impact on RV and overall lung compliance would be a deviation from safe and ethical practice, potentially causing harm. Professional decision-making in such situations requires a systematic approach. First, assess the patient's current ventilatory status and the prescribed therapy. Second, recall the definitions and clinical significance of VT, ERV, and RV within the context of the patient's diagnosis and current condition. Third, apply knowledge of U.S. regulatory guidelines for respiratory care, which emphasize patient safety, evidence-based practice, and the CRT's scope of practice in managing mechanical ventilation and assessing respiratory function. Fourth, consider the dynamic nature of lung volumes and how they are affected by disease, therapy, and patient effort. Finally, communicate findings and recommendations clearly to the supervising physician or advanced practice provider, ensuring collaborative and informed patient care. Question 14. The evaluation methodology shows that a patient diagnosed with idiopathic pulmonary fibrosis, a severe restrictive lung disease, is expressing significant anxiety and reluctance to initiate prescribed supplemental oxygen therapy, despite objective evidence of hypoxemia that is impacting their daily functional capacity. The patient states, "I don't want to be tethered to anything, and I'm afraid it will make me weaker." As a certified respiratory therapist, CRT, what is the most ethically and professionally appropriate course of action? Option A. Document the patient's refusal of oxygen therapy and proceed with their current care plan, assuming their decision is final and not exploring further. Option B. Refer the patient to a psychiatrist for evaluation, suggesting their reluctance is a manifestation of a psychological issue rather than a rational concern about treatment. Option C. Engage in a detailed, empathetic conversation with the patient to explore their fears and concerns about oxygen therapy, explain its benefits in managing symptoms and improving functional capacity, and collaboratively develop a plan that addresses their anxieties and respects their autonomy. Option D. Strongly advocate for the immediate initiation of oxygen therapy, emphasizing the severe consequences of untreated hypoxemia and downplaying the patient's expressed fears to ensure compliance. The correct answer is C. Engage in a detailed, empathetic conversation with the patient to explore their fears and concerns about oxygen therapy, explain its benefits in managing symptoms and improving functional capacity, and collaboratively develop a plan that addresses their anxieties and respects their autonomy. Explanation. This scenario presents a professional challenge due to the conflict between a patient's expressed wishes and the perceived best interest of their health, particularly when dealing with a progressive and potentially life-limiting restrictive lung disease. The certified respiratory therapist, CRT, must navigate ethical principles of autonomy, beneficence, and non-maleficence, while adhering to professional standards and regulatory guidelines. The patient's refusal of a recommended treatment, even if it could improve their quality of life or slow disease progression, necessitates a careful and respectful approach that prioritizes informed consent and patient autonomy. The correct approach involves a thorough and empathetic discussion with the patient to understand the root of their refusal, explore their values and goals, and ensure they have received comprehensive information about the treatment's benefits, risks, and alternatives. This approach upholds the ethical principle of patient autonomy, which is paramount in healthcare. Regulatory frameworks for CRTs emphasize the importance of patient-centered care, informed consent, and respecting patient decisions, even when those decisions differ from the clinician's recommendations. The CRT's role is to educate and support, not to coerce. An incorrect approach would be to disregard the patient's refusal and proceed with the treatment without further discussion or consent. This violates the ethical principle of autonomy and could be considered battery or a breach of professional conduct, potentially leading to disciplinary action by regulatory bodies. Another incorrect approach would be to dismiss the patient's concerns as unfounded or irrational without attempting to understand their perspective. This demonstrates a lack of empathy and respect for the patient's lived experience, undermining the therapeutic relationship and failing to meet the ethical obligation of beneficence by not adequately addressing the patient's underlying reasons for refusal. Finally, pressuring the patient or making them feel guilty for their decision is also ethically unsound, as it manipulates their decision-making process and fails to respect their right to self-determination. The professional decision-making process in such situations should involve 1. Actively listening to and acknowledging the patient's concerns. 2. Eliciting the patient's understanding of their condition and treatment options. 3. Exploring the patient's values, goals, and fears related to the treatment and their disease. 4. Providing clear, unbiased information about the recommended treatment, its potential benefits, risks, and alternatives, in a manner the patient can understand. 5. Collaboratively developing a care plan that respects the patient's informed decision, even if it means choosing a less aggressive or alternative course of action. 6. Documenting the discussion and the patient's decision thoroughly. Question 15. During the evaluation of a patient presenting with acute dyspnea and hypoxemia, the respiratory therapist notes findings suggestive of impaired blood flow through the pulmonary arteries. Which of the following approaches best reflects a risk assessment strategy aligned with the Certified Respiratory Therapist (CRT) regulatory framework? Option A. Immediately initiate high-frequency oscillatory ventilation to maximize alveolar recruitment and improve oxygenation. Option B. Investigate potential causes of pulmonary vascular obstruction or dysfunction, such as pulmonary embolism or pulmonary hypertension, and assess their impact on gas exchange and hemodynamics. Option C. Prioritize assessment of airway patency and secretion management, as these are primary determinants of gas exchange. Option D. Assume the hypoxemia is solely due to a ventilation-perfusion mismatch and focus on optimizing ventilator settings for increased minute ventilation. The correct answer is C. Prioritize assessment of airway patency and secretion management, as these are primary determinants of gas exchange. Explanation. This scenario is professionally challenging because it requires the respiratory therapist to integrate knowledge of pulmonary circulation with patient assessment and risk identification, all within the strict confines of the Certified Respiratory Therapist (CRT) regulatory framework. The therapist must not only understand the normal flow of blood through the pulmonary arteries and veins, but also recognize how deviations from this normal flow can indicate significant physiological compromise and potential risks to the patient. Careful judgment is required to prioritize diagnostic and therapeutic interventions based on the most likely underlying cause of altered blood flow. The correct approach involves a systematic assessment that prioritizes identifying potential obstructions or abnormalities in the pulmonary vasculature. This approach is right because it directly addresses the potential for life-threatening conditions such as pulmonary embolism or severe pulmonary hypertension, which are critical concerns within the scope of respiratory care. By considering the implications of altered blood flow on gas exchange and hemodynamics, the therapist aligns with the CRT's responsibility to monitor and manage patients with cardiopulmonary diseases. This aligns with the ethical imperative to provide competent care and act in the patient's best interest, as guided by professional standards that emphasize thorough patient evaluation and risk mitigation. An incorrect approach that focuses solely on ventilatory parameters without considering the circulatory component fails to acknowledge the interconnectedness of the pulmonary and cardiovascular systems. This oversight represents a regulatory failure by not adhering to a comprehensive assessment that is expected of a CRT. It also poses an ethical risk by potentially delaying the diagnosis and treatment of a critical circulatory issue. Another incorrect approach that dismisses the significance of altered blood flow as a secondary concern to airway management is also professionally unacceptable. While airway patency is crucial, ignoring the implications of compromised pulmonary circulation can lead to severe hypoxemia and hemodynamic instability, directly impacting patient outcomes. This demonstrates a failure to apply a holistic understanding of respiratory physiology and patient care, which is a cornerstone of CRT practice. Finally, an approach that relies on assumptions about the cause of altered blood flow without further investigation is a significant ethical and regulatory lapse. CRTs are expected to gather objective data and use critical thinking to form differential diagnoses, not to make speculative judgments. This can lead to misdiagnosis, inappropriate treatment, and harm to the patient, violating the fundamental principles of patient safety and professional accountability. The professional decision-making process for similar situations should involve a structured approach. 1. Recognize and interpret abnormal findings in the context of pulmonary circulation. 2. Formulate a differential diagnosis considering potential causes of altered blood flow. 3. Prioritize investigations and interventions based on the severity of the potential risks and the patient's clinical presentation. 4. Collaborate with other healthcare professionals to ensure comprehensive patient management. 5. Continuously reassess the patient's condition and adjust the plan of care accordingly. Question 16. The monitoring system demonstrates a sustained increase in peak inspiratory pressure and a plateau pressure that is disproportionately higher than the delivered tidal volume, suggesting increased airway resistance. The patient is currently on mechanical ventilation with a set tidal volume and respiratory rate. Which of the following actions best reflects the appropriate response for a certified respiratory therapist, CRT, in this situation? Adhering to U.S. regulatory frameworks and professional guidelines. Option A. Adjust the patient's position to alleviate potential external compression on the airways. Option B. Continue current ventilator settings and monitor the patient closely, assuming the changes are transient. Option C. Immediately increase the peak inspiratory flow rate to overcome the observed resistance. Option D. Perform a thorough assessment of the patient and ventilator circuit, considering potential causes of increased airway resistance such as secretions, bronchospasm, or circuit leaks, and communicate findings to the physician. The correct answer is B. Continue current ventilator settings and monitor the patient closely, assuming the changes are transient. Explanation. Scenario analysis. This scenario presents a common clinical challenge where a respiratory therapist must interpret physiological data in the context of airway resistance. The challenge lies in distinguishing between normal physiological variations and deviations that require intervention, while adhering to established clinical protocols and regulatory guidelines for patient care. Accurate assessment of airway resistance is crucial for effective mechanical ventilation management and patient safety, directly impacting treatment efficacy and preventing adverse events. Correct approach analysis. The correct approach involves recognizing that increased airway resistance, as indicated by the monitoring system, is a significant physiological finding that necessitates a systematic evaluation of potential causes. This evaluation must be guided by the certified respiratory therapist, CRT, scope of practice, as defined by the relevant U.S. regulatory framework. Specifically, CRTs are authorized and expected to assess patient response to therapy, interpret physiological data, and collaborate with the healthcare team to adjust treatment plans. The regulatory framework emphasizes evidence-based practice and patient advocacy, requiring the therapist to investigate the underlying factors contributing to the observed resistance, such as changes in airflow or airway caliber, and to communicate these findings promptly. This proactive and analytical approach aligns with the CRT's responsibility to ensure optimal patient outcomes and adherence to established standards of care. Incorrect approaches analysis. Ignoring the elevated airway resistance and continuing current ventilation settings represents a failure to adhere to the CRT's professional responsibility to monitor and respond to significant physiological changes. This inaction could lead to patient harm, such as barotrauma or inadequate gas exchange, and violates the ethical principle of beneficence. Attributing the increased resistance solely to patient positioning without further investigation is an incomplete assessment. While positioning can influence airway resistance, it is not the only factor, and a thorough evaluation is required to rule out other potential causes like bronchospasm, secretions, or equipment malfunction. This approach lacks the comprehensive analysis mandated by professional standards. Immediately increasing the peak inspiratory flow rate without a clear understanding of the cause of the resistance is a potentially harmful intervention. While increasing flow can sometimes overcome resistance, doing so without identifying the root cause could exacerbate underlying issues, such as increasing airway pressure and risking barotrauma, or mask a more critical problem. This reactive approach deviates from the systematic, evidence-based problem-solving expected of a CRT. Professional reasoning. When faced with abnormal physiological data, a CRT should employ a systematic decision-making process. This begins with accurate data interpretation, followed by a comprehensive assessment of potential contributing factors, considering the patient's overall clinical status and history. The next step involves consulting relevant clinical guidelines and protocols, and then collaborating with the physician or other members of the healthcare team to formulate an appropriate intervention. Documentation of findings and interventions is also a critical component of professional practice. This structured approach ensures that patient care is safe, effective, and compliant with regulatory requirements. Question 17. Performance analysis shows a patient with a known history of COPD and chronic hypercapnia who is currently experiencing increased dyspnea and documented arterial blood gas, AB, results indicating a worsening respiratory acidosis, is refusing supplemental oxygen therapy. The patient states, "I don't want that stuff, it makes me feel worse." As a certified respiratory therapist, CRT, what is the most appropriate course of action? Option A. Inform the patient that their refusal is clinically inappropriate and that you will be notifying the physician to override their decision. Option B. Immediately administer supplemental oxygen at a low flow rate, as per standard protocol for COPD patients with hypoxemia, to prevent further deterioration. Option C. Gently explain the risks of hypoxemia and the potential benefits of carefully titrated oxygen therapy. Assess the patient's understanding of their condition and the rationale for the therapy, and explore their specific concerns about feeling worse, while documenting the conversation and the patient's decision. Option D. Document the patient's refusal and leave the room, respecting their autonomy without further intervention. The correct answer is C. Gently explain the risks of hypoxemia and the potential benefits of carefully titrated oxygen therapy. Assess the patient's understanding of their condition and the rationale for the therapy, and explore their specific concerns about feeling worse, while documenting the conversation and the patient's decision. Explanation. This scenario presents a professional challenge due to the inherent conflict between a patient's stated wishes and the therapist's clinical judgment, particularly when those wishes could lead to harm. The therapist must navigate ethical principles of autonomy, beneficence, and non-maleficence, all within the framework of the Certified Respiratory Therapist, CRT, scope of practice as defined by relevant U.S. regulations and professional guidelines. The core of the challenge lies in balancing the patient's right to refuse treatment with the therapist's responsibility to provide appropriate care and prevent adverse outcomes related to respiratory compromise. The correct approach involves a thorough assessment of the patient's understanding of their condition and the implications of their refusal, followed by clear, patient-centered communication. This approach aligns with the ethical imperative to respect patient autonomy while also fulfilling the duty of beneficence by ensuring the patient is making an informed decision. Regulatory frameworks for CRTs emphasize patient education and the importance of informed consent. If a patient refuses a necessary intervention, the therapist must document the refusal, the patient's understanding, and any alternative recommendations made. This upholds the principle of informed consent and protects both the patient and the practitioner. An incorrect approach would be to immediately override the patient's wishes and administer the therapy without further discussion or assessment. This violates the principle of patient autonomy and could be considered battery if done without consent. It also fails to address the underlying reasons for the patient's refusal, which might stem from fear, misunderstanding, or other factors that could be mitigated through communication. Another incorrect approach would be to simply document the refusal and walk away without further engagement. This neglects the therapist's duty of beneficence and non-maleficence, as it fails to ensure the patient fully comprehends the risks of their decision and does not explore potential alternatives or supportive measures. Finally, pressuring the patient aggressively or using coercive language to force compliance would be unethical and unprofessional, undermining the therapeutic relationship and potentially leading to a breakdown in trust. Professional decision-making in such situations requires a systematic process. First, assess the patient's capacity to make decisions. Second, clearly and empathetically communicate the clinical findings, the rationale for the recommended intervention, and the potential consequences of refusal. Third, explore the patient's concerns and reasons for refusal. Fourth, offer alternatives or modifications to the treatment plan if feasible and appropriate. And fifth, document all interactions, assessments, and decisions thoroughly. This process ensures that patient care is both ethically sound and clinically appropriate, adhering to the standards of practice for a CRT. Question 18. Risk assessment procedures indicate a patient experiencing increased dyspnea and visible accessory muscle use during respiration. Auscultation reveals diminished breath sounds and audible wheezing. Which of the following physiological factors is most likely contributing to an increased work of breathing in this patient? Option A, increased dead space. Option B, hypoxemia. Option C, decreased lung compliance. Option D, increased airway resistance. The correct answer is D, increased airway resistance. Explanation. This scenario is professionally challenging because it requires the respiratory therapist to identify the primary factor contributing to an increased work of breathing in a patient with a complex respiratory condition. Accurate assessment is crucial for effective treatment and patient outcomes, and misidentification can lead to inappropriate interventions. Careful judgment is needed to differentiate between various physiological and mechanical factors that can elevate the work of breathing. The correct approach involves recognizing that increased airway resistance directly impedes airflow, forcing the respiratory muscles to generate higher pressures to achieve adequate ventilation. This aligns with fundamental respiratory physiology and the principles of respiratory care as outlined in the Certified Respiratory Therapist (CRT) scope of practice, which emphasizes understanding and managing factors affecting ventilation and gas exchange. The regulatory framework for CRT practice mandates a thorough understanding of respiratory mechanics and the ability to assess and intervene in conditions that compromise breathing. An incorrect approach would be to focus solely on the patient's oxygen saturation. While oxygen saturation is an important vital sign, it is a measure of gas exchange efficiency, not a direct indicator of the effort required to breathe. Elevated work of breathing can occur with normal or even high oxygen saturation if the underlying issue is mechanical obstruction. This approach fails to address the root cause of the increased breathing effort and could lead to interventions that do not resolve the patient's dyspnea. Another incorrect approach would be to attribute the increased work of breathing solely to the patient's anxiety. While anxiety can exacerbate dyspnea and lead to hyperventilation, it is often a secondary response to underlying physiological distress. Focusing solely on anxiety, without addressing the primary mechanical impediment to breathing, would be a failure to provide comprehensive respiratory care and could delay necessary interventions. A further incorrect approach would be to assume that a normal respiratory rate indicates no increased work of breathing. Respiratory rate is a compensatory mechanism. A patient may maintain a normal respiratory rate by expending significantly more muscular effort, thus increasing their work of breathing, even if the rate itself has not yet become tachypneic. This approach overlooks the qualitative aspect of breathing effort and focuses only on a single quantitative measure. The professional decision-making process for similar situations should involve a systematic assessment of the patient's respiratory status. This includes evaluating the patient's subjective experience of dyspnea, observing their breathing pattern and accessory muscle use, assessing airway patency, lung compliance, and the presence of any mechanical impediments to airflow. Understanding the interplay of these factors allows for the identification of the primary driver of increased work of breathing, guiding appropriate therapeutic interventions in accordance with the CRT's scope of practice and ethical obligations to provide patient-centered care. Question 19. The efficiency study reveals that patients exhibiting a markedly irregular and unpredictable breathing pattern, characterized by periods of apnea interspersed with shallow, gasping breaths, are most likely experiencing primary dysfunction within which specific brainstem respiratory center, necessitating a focus on augmenting central respiratory drive. Option A, the apneustic center of the pons. Option B, the ventral respiratory group of the medulla oblongata. Option C, the pontine respiratory group pneumataxic center. Option D, the dorsal respiratory group of the medulla oblongata. The correct answer is D, the dorsal respiratory group of the medulla oblongata. Explanation: this scenario is professionally challenging because it requires a respiratory therapist to interpret complex physiological data in the context of specific regulatory requirements for patient assessment and intervention. The therapist must demonstrate a thorough understanding of how the brainstem respiratory centers function and how their dysfunction can manifest, while adhering to the established standards of practice and guidelines for certified respiratory therapists, CRT. The core of the challenge lies in accurately identifying the primary site of respiratory control disruption based on observed clinical signs, and then selecting the most appropriate therapeutic strategy, all within the defined scope of practice. The correct approach involves a systematic evaluation of the patient's respiratory pattern and associated neurological signs to pinpoint the likely origin of the respiratory compromise within the brainstem. This requires understanding the distinct roles of the medulla oblongata and the pons in regulating breathing. Specifically, damage or dysfunction in the medullary centers, dorsal and ventral respiratory groups, typically leads to more profound and life-threatening alterations in breathing patterns, such as apneustic breathing or ataxic breathing, often indicative of severe central nervous system depression or injury. The pons, on the other hand, primarily modulates the rate and depth of breathing, with lesions here potentially causing patterns like apneustic breathing, prolonged inspiration, or pneumataxic breathing, inhibition of inspiration. CRT's responsibility is to correlate these patterns with potential underlying pathologies and to initiate interventions that directly address the identified respiratory drive issue, in accordance with established protocols and physician orders. This approach aligns with the CRT's ethical obligation to provide competent and safe patient care, prioritizing patient well-being, and adhering to the scope of practice defined by regulatory bodies. An incorrect approach would be to focus solely on peripheral factors or to implement interventions without a clear understanding of the central respiratory drive. For instance, assuming a patient with a severely irregular and shallow breathing pattern is experiencing solely a problem with lung compliance and initiating aggressive bronchodilator therapy without assessing central respiratory drive would be a failure. This neglects the primary regulatory issue and could be ineffective or even detrimental. Another incorrect approach would be to misinterpret the breathing pattern, attributing a medullary dysfunction to a pontine issue or vice versa, leading to an inappropriate therapeutic strategy. This demonstrates a lack of understanding of the specific functions of these brainstem centers and their characteristic clinical presentations, violating the standard of care expected of a CRT. Furthermore, any intervention that exceeds the CRT's scope of practice or bypasses necessary physician consultation would represent a significant regulatory and ethical failure. Professional decision-making in such situations requires a structured approach. First, a comprehensive assessment of the patient's respiratory status, including pattern, rate, depth, and oxygenation. Second, a critical analysis of the observed signs to infer the underlying physiological mechanism, specifically considering the roles of the medullary and pontine respiratory centers. Third, consultation with the physician to discuss findings and collaboratively develop a treatment plan. Fourth, the implementation of evidence-based interventions within the CRT's scope of practice, with continuous reassessment of the patient's response. This systematic process ensures that interventions are targeted, safe, and aligned with regulatory requirements and ethical principles. Question 20. The performance metrics show a patient's lung volumes, including a reduced inspiratory capacity (IC), a normal functional residual capacity (FRC), a decreased vital capacity (VC), and a significantly reduced total lung capacity (TLC). Considering the certified respiratory therapist (CRT) scope of practice within the United States, which of the following approaches best reflects the appropriate professional response to these findings? Option A. Integrate these lung volume findings with the patient's clinical presentation, history, and other diagnostic data to formulate a comprehensive assessment and guide further diagnostic or therapeutic interventions. Option B. Conclude that the patient has a severe restrictive lung disease based solely on the reduced TLC and VC, and recommend immediate pulmonary rehabilitation. Option C. Immediately initiate bronchodilator therapy, assuming an obstructive process is present due to the reduced IC and VC. Option D. Focus on the normal FRC as an indicator of adequate expiratory reserve volume, and disregard the other reduced lung volumes as potentially inaccurate. The correct answer is C. Immediately initiate bronchodilator therapy, assuming an obstructive process is present due to the reduced IC and VC. Explanation: the performance metrics show a patient's lung volumes, specifically inspiratory capacity IC, functional residual capacity FRC, vital capacity VC, and total lung capacity TLC. The challenge lies in interpreting these values within the context of the patient's clinical presentation and ensuring that the chosen therapeutic or diagnostic approach aligns with established respiratory care standards and regulatory guidelines for certified respiratory therapists, CRT, in the United States. Accurate interpretation is crucial for effective patient management, preventing misdiagnosis, and ensuring patient safety, all of which are paramount under the scope of practice defined by the National Board for Respiratory Care, NBRC, and state licensing boards. The correct approach involves a comprehensive assessment that integrates these lung volume measurements with the patient's history, physical examination findings, and other diagnostic data. This holistic view allows for a nuanced understanding of the patient's respiratory status, enabling the CRT to identify potential underlying conditions such as restrictive or obstructive lung diseases, or to monitor the progression of known conditions. This aligns with the NBRC emphasis on critical thinking and problem-solving in respiratory care, ensuring that interventions are evidence-based and patient-centered. Ethical practice dictates that CRTs act in the best interest of the patient, which necessitates a thorough and integrated interpretation of all available data. An incorrect approach would be to solely focus on one or two lung volumes in isolation, without considering the broader clinical picture. For example, assuming a restrictive pattern based solely on a reduced TLC, without considering the patient's symptoms or other spirometric values, could lead to an inappropriate diagnostic pathway. This fails to meet the standard of care expected of a CRT, which requires a comprehensive evaluation. Another incorrect approach would be to make therapeutic decisions based on a single abnormal lung volume, without confirming the findings or considering alternative explanations, potentially leading to ineffective or harmful treatments. This contravenes the ethical obligation to provide competent and safe patient care, as outlined by professional organizations and regulatory bodies. Furthermore, failing to document the rationale behind the interpretation and subsequent recommendations would be a breach of professional responsibility and regulatory compliance, as accurate record-keeping is a fundamental requirement for all healthcare professionals. The professional decision-making process for similar situations should involve a systematic approach. First, gather all relevant patient data, including lung volumes, clinical history, physical assessment, and other diagnostic tests. Second, interpret the lung volumes in the context of the entire clinical picture, considering potential causes for any deviations from normal. Third, consult with the supervising physician or other healthcare team members as needed. Fourth, formulate a differential diagnosis and a plan for further investigation or treatment. Finally, document all findings, interpretations, and recommendations clearly and comprehensively. This structured approach ensures that decisions are well-informed, evidence-based, and ethically sound, adhering to the established scope of practice for CRTs.